Dr. SAUMIL KOTHARI, everybody knows, a Bombayites, a senior faculty. He will talk us regarding the how to manage the high myopia, very high myopia, hyperopia, very high hyperopia. Patient has undergone the vitrectomy surgery. How to manage those cases for the IOL power calculations. Dr. SAUMIL, please.
Thank you. It's good to see all of you after, I think, 2 years, having back to face-to-face conferences at the All India level. And it's going to be a wonderful conference in this wonderful venue of Geo World Convention Center. While they are setting up my slides, I thank Dr. Twinkle to include me in this course, in this fantastic course of very important of how to do your IOL power calculations. And my talk is on how IOL power calculations will be done in very short, very long, and post-vitrectomy eyes. Thank you. Lovely. Thank you very much. So I divide my talk into two parts. One is about short and long eyes, and the second one is about post-vitrectomy eyes. Now, coming to short and long eyes, what are short and long eyes, first of all? Well, we all know the bell curve, and 95% of us, what we in so-called normal, will fall into the normal category, and on the either two ends are the 2.5% and 2.5% of the extremes. So this is where the short and long eyes come into play. Normally we say that less than 22 millimeters of axial length is considered short, and various studies have said that either you can consider more than 25 or 25.5 or 26 is considered as long eyes. So what's the problem with short and long eyes? Well, there is no problem actually. It's just about the expectations of our patients from the cataract surgery itself. Everyone wants a perfect outcome after cataract surgery, so the expectations are running very high. And in reality, although we all give good, perfect outcomes as far as refractive error is considered in the normal category of eyes, as far as short or long eyes is concerned, we sometimes fall short. And that's where there's a mismatch between expectations and reality. So what's the solution? How do we achieve target refraction in such eyes? Well, there are two components to better biometry. One is having better equipment, and second is better IOL calculation formulae. Let's talk about each one. Coming to the equipment, as Harshul has very eloquently mentioned, it's very important to update ourselves and have the best biometers which are there available. There are many such biometers which are available. Just to very commonly available instruments are the LensStar and the IOL Master, and we should invest in such modalities because they really help us in difficult situations. So the advantages of these optical biometers are they measure the true axial length. They give us the central K measurements. They are highly accurate and repeatable, and they are non-contact. They have faster measurements so that the patient eye fatigue time is less, and some of them have inbuilt newer IOL calculation formulae as well. So then what is the role of the old ultrasound biometry? So it is still used for dense cataracts whose axial lengths cannot be ascertained by optical biometers, and also for confirmatory role for doubtful measurements obtained by the optical biometers. So this comes to the biometry part. Let's talk about the IOL calculation formulae in short and long eyes. So there are various formulae available. Which formula to choose is always a conundrum. So I've just broadly divided into the older and the newer formulae. So the older formulae, like the SRK1, SRK2, were based on regression and basic theoretical optics, whereas the newer ones are based on more advanced theoretical optics, either or ray tracing or artificial intelligence. In the older ones, only 2-3 variables were accounted for, and here there are many more variables which are accounted for, leading to more accurate outcomes. And the older ones were less accurate in extremes of actual length, and definitely the newer ones are more extreme, more accurate in terms of as compared to the older formulae. So this is how the newer formulae, the newer generation formulae like the Barrett, the Olson, the Kane, they all work very well. So how do the formulae compare? Well, I've borrowed heavily from this article which was there in ophthalmology, and it compared 8 different formulae, the newer ones as well as some of the older ones. So let's talk about the variability with the IOL power. Well, you can see the more variations in the formulae, the less accurate it is. We want a formula which is very stable. We want a straight line more or less across the board, across whether it's a very hypermetropic IOL power or a very myopic IOL power which is used. And here you found out that more or less the red line, which is Barrett, as well as the purple line, which is the Olson, fared very well. Variability with axial length, which is my core topic. Again, you can see the flat line is more consistency, is with the Barrett again, and the Haggis without the Van Gogh modification fared very well. But somehow with the Van Gogh, they found out that it didn't really serve very well in the longer axial lengths. With K readings also, they did study that. And again, it showed that the Holiday and the Barrett were quite repeatable across the board with the keratometry readings. As well as with AC depth, again the Barrett and the Haggis fared very well. Somehow the Olson didn't do very well with the AC depth. And they studied the lens thickness. More or less, almost all the formulae were comparable except for the Haggis formula. Now this graph talks about the prediction errors based on the axial length. Here we are talking about the shorter axial length, which is blue. The green is the normal, and the red is the longer eyes. And here these are prediction errors. So the bars should be as less as possible. The longer the bar, the more error it is. So here you can see in the leftmost there are minimum bar height, which is there in the Barrett and Olson, and towards the right we go with the increasing bar. So it's again, this shows that the Barrett and Olson is quite good in across the board of axial lengths. And what about the ultimate refractive error? How many number of cases were on target refractive error? Here it showed that less than 0.25 prediction error was there between 42 and 50% of the eyes across the board, but again slightly more in the Barrett, and also less than half a diopter as compared to the target variability was there between 72 to 80% of the eyes, again more so in the Barrett and Olson. So this is a range which Dr. Twinkle has also shown this slide, that this newer formulae work across a long range of axial lengths. So what's the long and short of it ultimately? If you take one slide, this is it. This is a take-home message, that the Barrett is what I use, the Barrett Universal 2 formula has emerged for all of us, for at least most of us, as a go-to formula for all axial lengths. Let's talk about post-vitrectomized eyes. What's the problem with post-vitrectomized eyes is about silicone oil, essentially. So how to have the correct axial length measurement in silicone oil-filled eyes? What about getting the correct IOL power? And the third and the last part is choosing an appropriate IOL material in silicone oil-filled eyes. Again, let's talk about each one in length. So why is silicone oil a problem? Well, silicone oil reduces, the conduction of speed in silicone oil is slower than that of vitreous. In vitreous, it's 1532 meters per second. Whereas in a silicone oil, it's either 980 for the lesser centistokes, that is 1000 centistokes silicone oil. And if we use a 5000 centistokes, it is 1040. Also, the higher refractive index of silicone oil leads to a hypermetropic shift of refractive error by around 5 diopters, anything between 4 and 8 diopters. Also, when we take our measurements, there is poor quality of echoes, and there is reduplication of echoes on the ultrasound. So what's the solution? Well, if you have a basic biometer, Very simply, you can use a correction factor of 0.71. It is studied, and which is used for the more commonly used of 1300 centistokes silicone oil to measure the correct axial length. For example, if you have a axial length which is measured of, it shows 37.5. Silicone oil filled eyes in the normal mode, it gives a very long axial length. You just multiply it by 0.71, so you get the correct axial length of 26.63. This is what you can use as a basic formula. But better still is to change the mode to silicone oil fill eye if your biometer allows. And of course, the best one is to use optical biometers like the LensStar or the IOLMaster 700, because you don't really have to do anything much. It gives the absolute correct axial length. But what if you don't get a good scan? Well, what very important preemptive solution is to measure the axial length prior to VR surgery, so that we can use this at a later date when we are going ahead with the cataract surgery. Also, the second one, another thing which we can do is that we can remove the silicone oil and then remeasure the axial length and then later on implant the IOL. Also, which is studied is intraoperative aberrometry or retinoscopy, which deals with removing the oil, doing a retinoscopy, and then intraoperatively, and then going ahead with the IOL selection. Or lesser accurate is using the axial length of the contralateral eye. So this is about the correct measurement of the axial length itself. Talking about IOL, briefly about IOL power calculation in such situations. This was an article which studied 8 formulas again, which combined phaco-vitrectomy, and it showed that you can see on the top, the Kane and the Barrett Universal 2 fared better than the others, albeit by a slight margin. And the third part is about which IOL material to choose. Well, we all know that we have to avoid silicone oil in such situations, and best to use either acrylic or PMMA lenses. So what are the conclusions in summary? Use newer biometers to measure the axial length accurately. Use newer formulae like Kane or Barrett for IOL power calculations, and avoid silicone material of IOLs. So as Shakespeare would put it, oil's well that ends well. Thank you.
The Indian Shakespeare.
Thank you, Dr. SAUMIL, for such a nice narration about the post-vitrectomized eyes and the very high axial lengths. Any questions regarding it? Yeah, you can start.
Just for the clarification of the audience, Saumil, I always get confused that, when the oil is in the eye, what power do you choose? So could you guide that if the oil is to be removed or if it is not to be removed, from what you measure, what power should you keep?
Very true. So there are two situations. Either we are intending to remove the oil at a short, and to keep the oil only for a short duration, or we intend to keep the oil for a longer duration. So all this what I spoke was only to intention with to keep the oil for a shorter duration, then you do all these things. But if you really want to keep the oil for a longer duration, then what I do is simply just add around 5 diopters to the IOL power which is calculated, and then implant that because of the higher refractive index and the hypermetropic shift which happens.
So that basically means you choose a more myopic target. So in your biometry, just say put a target of -4, and whatever the power comes, you choose that.
Exactly. Yeah. So if the IOL power calculation comes out to be 20, I'll just choose 25 or 26, something like that. Thanks.
Excellent. And Dr. Tejas.
Yeah, in fact, adding more to it, that's what is our general fundamental. What would you prefer, a patient with 6/9 vision and ametropia, or a patient with 6/6 vision but plus 2.5? Well, definitely, that's the reason we always want to err on the myopic side with silicone or without silicone.